Yes, so this is a retrospective study that I did at my internship center, which is Karatina Sub-County Hospital. As mentioned, I am interested in oncology, specifically the preventive aspect. So I was looking at the patterns of cervical and breast cancer screening, utilization, and outcomes at our facility. So the total, we had 850 cervical screens. For the clinical breast examinations, we had 4,448. For eligible women of reproductive age in our catchment area, it's 21,145, and that gives us about 4% coverage rate. But I will expound on this as we continue. So just to paint the picture, for cervical cancer in our country, we have about 5,845 cases every year. And from the 5,000, we have about 3,591 people dying. Then to bring it closer, in Nyeri, our prevalence is at 5.16, but the survival rate is only 58.3. The current updated, the data is from 2022, national screening uptake is at 16.8. giving us about 9 women dying daily from cervical cancer, but I'm sure you guys know that. Then for breast cancer, we have about 6,799. We know it's the most common of the female cancers in our country, and I think actually globally, giving us about 23% of all female cancers. And we noted, from our data, most diagnoses happening at stage 4, which is at 37.2. For the national CBE uptake, we had at 13%. In our facility, we have about 21% expected new cases, and that one you'll see it also from the data. This was just, okay. So our projected catchment population in 2025-2026 at Karatina is about 81,000. So for our WRA, which is 26% of the population, we have about 21,000 women of reproductive age. At our OPD, within the 6 months, we saw about 22,000 patients, and specifically at MCH and family planning, we saw 4,800 patients. So, but of note, look at the WRA, the 21,000, because that's what we will use to compare against how many women we screened, so that we see, are we having enough women coming to be screened or not? So, as I mentioned, the eligible women in the catchment area is about 21,000, yeah? But in the 6 months, we had about 850. So, the national rate for Kenya is about 16.8. But when we do now this percentage, it gives us about 4%, yes. So we have a gap of about 76%. So as you can see, if you just see the 850 number, it can sound big, but when you compare it to the bigger population, you see there is a bit of underutilization of those services. And then with the WHO, we know the 90-70-90, whereby the 70% is for the screening. So when you compare that, we should be screening at least something close to 14,000. So with that also, we are really, again, you can see that we are still underutilizing the screening options. And when you, with projections, if we continue at that rate, we'll probably reach the WHO requirement in 8 years, which is a bit far, because the target was to be 2030, right? Which is 4 years from now. So again, that is a need. So this is a screening. This was the attendance. So mostly you will see a lot of HPV testing. So we have the Via Villa HPV test and the pap smear. They vary every month. So to highlight the ones that really stand out, so when you look at February, there is quite a spike. To note, there was a donor-funded HPV campaign, and you were able to do 281 HPV tests. So in January, there wasn't much going on because in January, that's when they did the sensitization, and then they did the testing in February. Then in March, we also had the highest via this month. It reflects the post-sensitization effect. However, if we look at April, things are getting worse. It's just going slower. To note, by this time, the donor had left. Also, pap smear has been quite consistent, although as you can see, it's less compared to the other ones. So we had about 112 smears taken, but note, over the 6 months, we had 0 results. Yes, and we'll talk about that more. For the outcomes, so we had a 10.6% via positivity. It's slightly above the 5 to 10% global benchmark. However, it is acceptable for a high HIV burden setting, which we are in. For the HPV, we had it at 27.8. It's high, but it is consistent with the Kenya estimated HPV prevalence of 25 to 35. For the suspicious lesions, we had 2 of them. We identified them and we referred them. In this case, our referral point is Nyeri PGH. Again, for the cytology results, over the 6 months, we had none. And this is something that, upon talking to the MCH team, say that it's quite a concern and it's been happening for a while. Okay, so for the pre-cancer treatment utilization, of the 28 that had positive outcomes, 27 were treated using thermoregulation and 1 using LEAP. So thermoregulation is a main form of pre-treatment utilization at our facility. For these other ones, we tend to also just refer them to the Nyeri PGH. There's a month-by-month analysis. As you see, in January, we were able to have 100% pre-cancer treatment, so that was good. And when you check the percentage of the treatment uptake, I think it's quite fair at 77.8. As I mentioned, we are in a high HIV burden community, so of the 850, 165 were HIV positive patients, and that gives us about 19.4%. So the Kenya national HIV prevalence is 6.3, so we are 3 times above that, and that's just indicative of a good HIV, or rather CCC, and cancer screening, integration, which I would like to commend our facility. So there's that. For the breast cancer screening, because they happen all at the same time, we had about 4,000 clinical breast exams done, and from the 4,000, about 9 were abnormal. From the 9 abnormal, only 5 got imaging, 2 ultrasound, 3 mammograms. And then, so that is quite not an ideal imaging follow-up rate. And then for the 0.22 abnormality rate, I don't know if we are just good, but it's a bit questionable if you look at those numbers. But yes. So now to this, because this was one of the main objectives of this review. So as I mentioned, out of the 112 pap smears done, we did not get any cytology results. So the main issue is we only have actually, I say few pathologists, but we only have 1 pathologist in the county. And with that happening, patients keep coming. When you tell a patient you have positive results and then they leave you to take them to the county, you tell them you can come, like after a month, they come, nothing. We've seen how it tends to actively discourage patients to return for screening. So yes, and we also have delays in management of abnormal results. So that's a very critical issue. The second one is the donor-dependent HPV testing, which we did see with the fluctuations of screening in the different months. So we say that we had 399 HPV tests in 3 months, and then 0 in the following 3 months. And all this, about 111 HPV women with no sustainable retesting or follow-up pathway for a burden that was, for a disease that we're saying it's killing 9 women every day. I think it's only right that there is better investment, beyond just donor. And then there is a sensitization-driven attendance that first, at least we know that sensitization is working. So I think it's either we do it more often or we create a system that is continually sensitizing people about the need of cervical cancer and breast cancer screening. And then last but not least, incomplete breast imaging follow-up. As I mentioned, out of the 9, only 5 were able to get follow-up imaging. That's still not ideal. And yes, we do not have a recall system to track abnormal findings all the way to diagnosis. There is a bit of, I don't know if it's a data issue, but we're not able to know what happens to the patients beyond that. Once we refer them, it's out of our hand. And I think it's happening in most of our facilities. But I think in terms of holistic care, because at the end of the day, the patients came to our facility first because they probably live in the area, so we are not able to follow up. But I think that's a bigger issue than this. Okay. I'm almost done though. So this are my recommendations. Maybe we just get another pathologist, guys. Maybe this is the wrong room, but in case you're talking to other people and they're wondering, oh, does this county need more? Just a pathologist. And I think that's the beauty of medicine, right? It's a very multidisciplinary team. You realize you cannot thrive without the other one, so you could be doing such a good job, managing all these cases and doing the sensitization, but then if this other department is not working, then it just, the net effect is not ideal. So there's that. And then, as I mentioned, sustainable HPV DNA testing, right? So we could have a county or a national budget line. We need to see more, this be taken a bit more, critically as it is, and then continuous sensitization. I know that we tend to do very silo or very focused sensitization. Like now in January, we will be seeing, January Cervical Cancer Awareness Month, and then boom, until the next year. Maybe we just need to adjust also on that. And then the breast image follow-up. So in conclusion, yes, the screening, treatment, and HIV integration are functioning. And as I mentioned, thermoregulation is the main form of pre-cancer treatment. The critical gap is that only 4% of eligible women of reproductive age have been screened, which is quite below the target, even at the country level. For the systemic barriers, we have the specialist shortage, specifically the pathologist. We have the donor dependence, which is quite unsustainable. And then for the pace of progress, at the current rate, we need at least 8.7 years to reach the WHO 70% target. And we only have about 4 years. So more campaigns won't solve this. We need more structural investment. And then, yes, as I mentioned, more domestic HPV funding, pathology investment, continuous sensitization, and for breast cancer, breast image follow-up. Thank you.
Thank you very much. As you can see, research can be done by interns.